Hi, everyone. It's good to be here for another episode of the Hem/Onc Pulse. I'm your host, Dr. Rahul Banerjee. I'm an assistant professor of medicine at the Fred Hutchinson Cancer Center in Seattle. And here it is my distinct pleasure to be joined by Dr. Eunice Wang. She's a professor of medicine at the Roswell Park Comprehensive Cancer Center in Buffalo, New York. She's chief of their leukemia service, and she's an active physician scientist with over 200 peer-reviewed publications and an H-index over 60. And she'll be here to speak about the trial of ziftomenib that was published earlier this year in JCO that led to the drug's approval in the U.S. Dr. Wang, Eunice, if I may, pleasure to have you here.
Every story has a pulse. Let's check the vital signs of what's happening right now.
Can you walk us through the updated science of NPM1 and AML? When I was a fellow, I remember NPM1 was good news, and perhaps it's not so good in the relapse setting, or there's more to it than that?
Yeah, so NPM1 is considered favorable risk for young, fit patients with AML that can get intensive chemotherapy, but is only considered good risk disease in the absence of a co-mutation in FLT3. So in that particular category, patients do very well with intensive chemotherapy, and many of them, 60% or more, can achieve long-term remission and potentially even cure with intensive 7+3 base regimens. But in the relapse setting, this is not a good disease. We would say anywhere from 40% or 50% of patients with NPM1 may eventually relapse. And at the time of relapse, with any relapsed acute myeloid leukemia, their outcomes are poor. With subsequent lines of therapy, their survival can range from anywhere between 5, 6, 7 months to even a few 2 or 3 months if they've had 2 or more lines of therapy and or if they've relapsed after allogeneic stem cell transplantation. So what the menin inhibitors do is they block the interaction between menin and transcriptome complexes in the leukemic cells. We know that, for example, there is a KMT2A master transcriptional complex, which results from the translocation of the 11q23 gene with many partner genes. We know that there's KMT rearranged leukemias. And by blocking the interaction between this menin, which is a nuclear scaffold protein, and the KMT2A transcriptional complex, that the menin inhibitors can really be transformative for the patients with KMT rearranged leukemias. It turns out that NPM1 mutant AMLs have a very similar transcriptome profile as KMT rearranged acute leukemias, and that menin interaction also can be blocked in NPM1 mutant, leading to similar effects as we see in KMT rearranged leukemias. It's kind of complicated, but we think the same underlying biology in KMT rearranged acute leukemias as NPM1 mutant leukemias.
Now, let's follow the flow. How does everything connect?
So let's dive into menin inhibitors. Can you tell us a bit more about the trial that you led, that was published earlier this year in JCO, the COMET-001 trial?
The COMET-001 trial was a phase 1 trial, which was actually performed in many different phases. We did a phase 1 dose escalation and expansion. This was the registration enabling phase 2 portion of the COMET-001, where we looked at the efficacy of ziftomenib, a novel potent selective menin inhibitor, specifically in patients who had NPM1 mutant relapse and refractory AML, had failed multiple lines of therapy, including prior allogeneic stem cell transplantation, and in many of these patients, prior venetoclax azacitidine. So in this trial, we enrolled 92 patients. Primary endpoint was looking at a CR/CRh rate, and we had examined what the literature had shown us, and the prior CR/CRh rate for these individual patients was somewhere in the range of 12%. So the ziftomenib is an oral menin inhibitor taken once a day at 600 milligrams for these patients. And what we found in these very heavily pretreated NPM1 mutant relapse refractory patients was that the overall response rate was about 33%. And the median duration of response was 4.6 months with an overall survival of 6 months. And this was positive as compared to our expected historic control CR/CRh rate of 12% with median survival in the 2 to 3 month range.
This is super helpful. And then toxicity-wise, I'm always interested in hearing about differentiation syndrome because obviously, as a fellow for me, I only learned in the setting of ATRA, but it sounds like there's many more to it. Did that happen in this trial? And if so, do you manage it any differently from class to class, or all differentiation syndrome kind of managed the same way it does occur?
So differentiation occurred in about a quarter of patients, and that's due to the underlying disease. When we block the menin interaction with this complex, it releases the differentiation block and allows these cells to differentiate and then go into terminal apoptosis. So this was something that we're seeing. We're seeing it differently with menin inhibitors. It happens usually in the first cycle, in the first 14 days. It can really be rapid, so it can really be exhibited by high white blood cell counts. Patients get short of breath. They get effusions. They can have life-threatening interactions. We have an algorithm that was defined on protocol. And with this algorithm, although we saw differentiation in 25%, only 15% was grade 3, and there was no severe grade 4 or 5 events. So it's something that one has to watch for and be observant to stop the drug if it doesn't improve with steroids. But certainly it would seem to be manageable with this particular agent. This is a class effect, and we've seen this with other menin inhibitors in clinical trial.
A steady pulse keeps us moving forward. Let's talk about what's next.
So then going forward, where do you see as a future for ziftomenib? So obviously that was in the relapse setting. If I recall correctly, there was an oral at ASH about combining with AZA and Frontline, and you had talked about how NPM1, for example, in Frontline is a little bit different than how it was in the relapse setting. Where do you see its future in the AML space?
So certainly, though, 20 to 30% overall response rate is enough to get approval in the relapse refractory setting with survival of just a few months. This is not anywhere near ideal for our patients. So we've been combining ziftomenib in clinical trial in combination with both 7 and 3, as well as with ven-aza. And data presented at the ASH 2025 meeting showed, number one, zifto can safely be combined with venetoclax azacitidine with reduced rates of differentiation syndrome as opposed to monotherapy. 2, you can actually improve the responses when you do combination therapy. So in the newly diagnosed setting, ven-aza combined with zifto for newly diagnosed NPM1 patients led to overall responses in like 90% of patients had an overall response. And there was very little differentiation syndrome. And in the newly diagnosed setting, the overall survival was not reached. In the relapse refractory setting, in NPM1 patients, the median duration of response was 10 months, which was really doubling or almost tripling of what we saw with zifto alone. And these drugs were really used primarily in patients that had failed prior intensive chemotherapy for their NPM1 mutant. So I think that seeing 40 to 60% response rates in relapse, 80 to 100% upfront, I think this is very promising.
So maybe I'll end with a more provocative question. I don't prescribe these drugs, so I would love to hear from someone who does. My understanding is that there are 2 menin inhibitors on the market, ziftomenib and revumenib. How do you compare, contrast them, choose between one or the other, or does it really depend on your hospital formula in terms of which one gets used?
So first of all, we do need both menin inhibitors. The revumenib, which is approved in both KMT rearranged and NPM1 mutant relapse refractory disease. Zifto is only approved for NPM1 mutant disease, so that's one important difference. There are, however, differences in toxicity. So revumenib causes significant QTc prolongation in 20 to 40% of patients. So patients with an underlying baseline QTc prolongation greater than 460 can't be treated with revumenib, and they're kind of at higher risk for some of those cardiac toxicities. Zifto does have some QTc, not as significant, doesn't have the same baseline contraindications. Zifto doesn't have the same amount of QTc prolongation, doesn't have a black box warning. Ziftomenib does not interact with other CYP3A inhibitors. You don't have to dose reduce with, for example, concomitant azoles. Revumenib you do. Ziftomenib you can't take with proton pump inhibitors. So there's some important drug interactions and safety. Ziftomenib is also once a day, as opposed to revumenib twice a day. But I think there are different patient populations, different safety profiles, and different drug properties that make it valuable to have both of these drugs on formulary or available for patients, because we really want more options for our relapsed leukemia patients, not less.
Very well stated. Thank you again for your time. And so, for you listening at home, thank you for listening to this episode of HemOnc Pulse. We'll see you on the next episode.